You're listening to the Animal Heartbeat. My name is Kieran Bourget.
Hi, and I'm Jose and Kieran. This is the world's only podcast dedicated to veterinary cardiology.
My honour to present the hosts of the Animal Heartbeat podcast, Kieran and Jose, and their wonderful panel. So everyone, please give them a round of applause.
So hi everyone, thanks very much for joining us. So we are the Animal Heartbeat, the world's only podcast dedicated to veterinary cardiology. And the best, the world's number one. Yeah, and thanks very much for joining. And I hope you enjoy the next hour.
And thanks for everybody attending today. We have a fantastic panel lined up here of vets who are working in primary care practice, who have agreed to join us and chat about the challenges, the wonderful aspects of managing cardiac patients in primary care. I'm going to let the panel introduce themselves.
Hello, I'm Rory Cowlam, Rory the Vet on social media. I am a GP vet of 10 years and co-owner and clinical director at Pickles in London.
Hi, I'm Kat. I'm a small animal vet in clinical practice as well. For longer than Rory, but I'm not going to tell you how long. And I'm very happy to be the useful idiot on this panel. So if anybody has got some very basic questions they'd like me to ask and pretend it was mine, that's fine.
This one? Hello? That's a complete lie, because I am actually the basic idiot. I'm a vet. I do a bit of TV work, a bit of writing work. My name's James, Dr. James Greenwood, and I am a self-confessed ultrasound-phobic, cardiology-confused general practicing vet.
Hi, I'm Louisa the Vet. If anyone follows me on social media, I'm I'm a small animal vet in Lancashire, and I do bits of ultrasound, which they've made me be the primary one to speak, which is not ideal because I won't shut up. But no, I'm looking forward to chatting about all things small animal, cardiac, imaging, all sorts.
You're in the right place for all things small animal cardiac imaging. So thank you, everybody, for coming. It's fantastic to be here.
So we thought we would start with cats. So as everyone knows, cats are challenging, and a cat with a heart murmur may be quite challenging both in primary care practice and referral practice. So can you share with us, how do you approach a cat, an asymptomatic cat with a heart murmur in your practice?
For God's sake.
And is it something that you find hard? Because I think we do identify that challenge.
Yeah, so I had to do a lot of CPD. I have done a certificate, so I did learn a bit more. But I think the challenge for myself and my younger colleagues is, when you do hear that cat with a heart murmur, do we need to investigate it or do we not? Because I have always been under the impression that, we'll all get these cats that come in dyspneic and it's terrible and we all panic, and we've never heard a heart murmur before and the owners don't understand why we've missed something, but we've not. So it's that, should we be investigating the ones with the murmur? Does that actually give us a clue that there's something going on and we need to keep an eye on it? Or should we actually be screening other cats without a murmur? Because actually they might be the ones that tend to be the ones that come in presenting dyspneic. My personal approach is that if there is a cat with a murmur, I will recommend investigation, so they probably will get an echo. I find cats incredibly difficult to ultrasound, I'll be honest, and colleagues probably will now recommend them to me, but I don't know what you guys do if you hear a murmur.
Yeah, I must admit, I'm probably a bit more hands-off. So I think the first thing I would do as a GP is explain what a murmur is, because I think there's a lot of misinformation and a lot of confusion about what we're saying to owners when we're saying, hey, there's a murmur. Because the amount of times I turn around and be like, oh, by the way, that doesn't mean there's heart disease. And they go, huh? And I think that's really the key of what I've learned. And I think that's the difference, I suppose, with a bit of experience. And what I see, we've got more experienced vets and we've got new grads. And I think the concern of a new grad when they're picking up a murmur, like, yeah, we must investigate, we must know what that is. I think actually sitting back and going, okay, well, if we look at the history, has it been picked up before? How old's the cat? How is it presenting? Is it soft? What's the grade? And taking all of that information. And I think the thing I've started doing more over the years, and I'll be interested in whether you guys do this, is going, okay, cool. Well, look, it could be 800 quid for a cardiac workup, but why don't you go away and come back in a month? And we'll have another listen. and why don't you give gabapentin before that trip? Because actually then we might mitigate a stress murmur or a hemic murmur. I don't know if that's commonly done. That's something that I've started to do, particularly when I'm more suspicious that it's a hemic murmur.
Absolutely. I think, so for me in general practice, I think behind dentistry, I think a heart murmur or cardiology is one of those topics that somehow just seems quite divisive. I find that clients will either come in, you know, you can diagnose it in the consult, you can go through all the options, you can tell them all the information you can possibly give them in a 20-minute consult, and they'll still basically either want to know everything about that murmur, or they'll kind of just be a bit like, yeah, well, I'll keep an eye for now. Yeah. And I think dentistry sort of has that same thing where it's kind of like trying to get across to a client that this is somewhat preventative, it's somewhat investigative, you know, there's sort of different aspects around it. I think it can be a real challenge. I think that's the big thing. And I think the really sort of maybe quite sort of disheartening thing about it is that actually a cardiac workup in the grand scheme of things in veterinary at the moment, you know, when you look at the cost of that, it's not necessarily the most expensive referral that you're going to be talking about. You know, you can get a huge amount of information off of the back of a referral. So I'm sort of chomping at the bit to try and encourage people to sort of say, should we go for a referral? And then it's kind of like, well, you know, I'll see how it is next year. And of course, you know, to get them coming back and blah, blah, blah. So I think it does carry its own challenge in the way of sort of communicating that contextualized care that everyone talks about to the client and actually getting them to act. You know, I think it can just be a real challenge.
So in terms of what I actually do, I try to, it depends how old they are, doesn't it? Whether they're,
sure.
my cutoff is under 10 and over 10. You can tell me if I'm wrong. And then, so I will offer scans, and I can scan, I think, most people can scan an aorta in a left atria, you know, as it flashes past the screen and you press pause and you wriggle it back. And, you know, scanning cats is hard. But I think if you can I think most people can learn to do those measurements. And I do try. And I listened once to one of Kieran's podcasts where he's like, well, if you're 1 millimeter out on measuring the atria, actually, sometimes it does skew the results.
Everything falls apart.
No. But essentially, you're just looking if it's massive and a problem or not. So I think that's relatively achievable, and it's and relatively affordable. And then I do their blood pressure. And we were chatting about gabapentin before we did this talk, and the great thing is GABA doesn't change it, does it? So you get gabapentin and you get gabapentin. Everybody gets gabapentin.
Yeah, it's the Oprah approach to gabapentin. Yeah,
which is really useful for us to know that, you know, because I think we worry if I sedate this cat or if I do anything to it, is it going to change that 1 millimeter that's so important? And then the other thing, and this is where I'm going to use this as like a helpful cases that I've actually got in real life, is proBNP and the blood tests.
That was my upcoming question. Was about, is it something that you find useful in that context where you have an owner and the owner's saying, I'm not really sure what it means, and you're going, yeah, it's a cat. I'm not sure what it means either. Is that something that helps you swing that decision, or do some clients perceive that as, oh, hang on a minute, what's the point of a blood test when there was this? And is it confusing to add that extra element?
Well, so only a couple of weeks ago, I scanned a cat and I said, oh, and I tell you what we'll do this blood test as well. And then the scan says everything's fine. The blood test will say everything's fine. That's two things that says everything's fine. Woo, the cat's fine. And the proBNP was really high. And the scan in my hands was fine. And so I was like, well, I don't really know what to do now. So it turns out that proBNP can sometimes make life harder than easy. And so now I want to know, Kieran, what do I do then?
Jose, do you want to field this one?
So yeah, I agree. I think BNP has been shown to be very useful in cats with murmurs. And as you were saying, the louder the murmur, the more likely the murmur to be significant. Normal cats might have murmurs, but most commonly they are soft. Really important to say that both bad murmurs and good murmurs may be dynamic. So the fact that the murmur goes away and comes back means nothing. But a cat with a murmur, and if you measure NT-proBNP and is increased, makes it very likely that the cat has moderate or severe disease. If it's normal, we cannot exclude mild disease. So the test is not great to detect mild disease. But then there will be false positives, certainly. What happens, I think what you said is also, I think NT-proBNP and echo a POCUS, point of care ultrasound, are really useful to determine which cats are more likely to have heart disease and decide if they need referral. Your case is complex, but what might happen is if you have a normal left atrium, but systolic anterior motion of the mitral valve, so abnormal movements of the mitral valve, that will markedly increase BNP, even though the left atrium looks okayish. And so there will be some cases with outflow tract obstruction, BNP will be sky high, and they are not close to congestive heart failure. But your approach will be exactly what we do and what we recommend. If NT-proBNP is high in a cat with a murmur, is most likely heart disease.
Can I ask about in-house snaps versus? Sorry, have I jumped the gun?
No.
So I mean, we have in-house snaps. Everyone's got the IDEX snaps, and we use those as a screening tool. Every time we use it as a screening tool, I go, I think it's telling me information that is useful. I'm unsure. And I think we've now moved towards, if you're going to do a BNP, you always do an LAAO as well. That's like a standard approach now in our clinic.
I think that's amazing. If you can combine the two, it makes it super powerful, I think.
Okay, good. And I suppose that then the follow-on question then as well would be, so what's the difference between external and in-house? Secondly, if you've got that dental, and you're going to dental, it's got a murmur. Is there anything wrong with just not using metatometine or an alpha-2 and just using a cardiac safe protocol in those instances? And if they have got some mild cardiac disease, what actually is the risk? Yes, we know there's an elevated risk, but I'm sure I've put a lot of cats with underlying cardiac disease under GA totally fine without any detriment.
Yeah, I think that's an incredible challenge, actually, and I've certainly worked with anaesthetists who they hear a murmur and they go, "Oh yeah, it's got a murmur," and they get on with it, and they very intelligently choose a nice, safe, balanced protocol. And I'm gutted because I want to do an echo, so my caseload plummets when you've got a really good anaesthetist who's really pragmatic. It's very, very challenging. I think if you're not sure, avoiding alpha-2s is a sensible move in that context, because alpha-2s increase cardiac work, they have a suppressive effect on systolic function, they increase preload. So if you've got mitral valve disease, if you're a dog, it's really bad for your left atrial pressure. I think choosing a kind of judicious protocol that keeps everything, heart rate, blood pressure, everything about the same as it was when they were awake, is probably safe without a big pre-GA workup. I think doing the point of care ultrasound, combining it with biomarkers is super, super helpful. But I think it's all about context, because if you screen using biomarkers and you think this patient is not high risk to begin with, then actually your positive result on the in-house snap test might be more likely a false positive than a true positive. And then it begs the question, well, what's the point if I'm not going to believe the result? I wanted to ask about the learning curve for point of care ultrasound, for POCUS, because when I give lectures and teach, I always say, oh, look how easy it is. I know that there's a learning curve there, and I wanted to hear about your experience of that learning curve. And how did you overcome the bumps in the learning curve there? Because it's not a super easy, intuitive skill, but with a bit of practice, it's accessible and straightforward, right? I think we all agree that. What's your experience of that?
So I pretty much just picked up the ultrasound scanner and started to play around with it. I have gone on CPD. Since, I would say, the last few years, I have become a lot more confident doing ultrasound, but it's because I have now done so much. I'm either Kieran on a daily basis with all my ultrasound queries when I still get stuck. But I think it's somewhat frustrating because I find it relatively straightforward to put the ultrasound scanner on. Sometimes I don't have a clue what I'm to expect, but you can just get a lot of information. That's how I feel, just by sticking the scanner on and what can I see or what can I not see. I've got a pleural effusion, right, drain it, done. And then if you can just, I almost feel like you don't have to think too much about what image you're trying to get. You put it on, you're just moving your hands around. If you can see that LAAO, in a second, you know, you've kind of got your answer on your next steps. But I think it's the confidence to pick up the scanner and start doing it, and the acceptance that, yeah, I might be a bit crap to begin with. I'm not really sure what I'm doing, but that's the same with anything. If you don't practice, you're never gonna learn, you're never gonna grow. And I haven't really had anyone to learn from in clinic, which is why I do my the Kieran a lot. And that's how I've learned and I've got more confident. I still have my challenges along the way and sometimes I'm struggling to interpret, but it's just practice and picking it up. And in time, you teach your colleagues and you learn from each other. So I don't know how you guys, James.
Well, so my relationship with ultrasound began in, I find ultrasound, it's a dark room. I get sleepy. I'm looking at the kind of screen, all this grey stuff. I'm getting tired. I'm getting hungry.
We've all been there, right?
It's normally lunchtime.
If it's 12, it's...
I'm staring at the screen saying, come on, just show me the answer. I wanted to just type across. Anyway, that never has happened. And so I'm still struggling along. I find that I can do the very basics and I'm, fine if I have to, but I am the default of, I love a ProBNP. I know there's subtleties around it, but for me, and again, going back, talking about communication, I find it a really useful tool to engage a client into that cardiac pathway. So if they're totally shut off from the idea in the first place, I find sometimes a blood test feels more accessible to a client than an ultrasound scan feels, that their cat's got to go through something invasive. Of course, ironically, the blood test is probably more invasive, but actually, I think that it's more palatable for a client to accept a blood test. But in terms of
can I just say that's a really good point. And there was a really nice study where they gave BNP and POCUS to general practitioners, and they could use either to decide how likely was those cats to have heart disease. And both NT-proBNP and POCUS were exactly the same. And so the vets were able to decide in a similar percentage which cats had heart disease with POCUS and NT-proBNP. We don't know if combining both would be even better, but just to say that approach is completely sensible and it can perfectly be done and is a good way to do it. And as you're saying, maybe you need to fill your client and based on how busy you are and if you know how to do POCUS and so on, some people may prefer blood test and other POCUS. Just to answer your question, because that's an important one, regarding point of care BNP versus quantitative, it lies in the lab, they are equally good. So the POCUS, the point of care, the SNAP test will turn positive around 120, 150. And many studies have shown that more than 100 is associated with underlying heart disease. So if you want to know a precise value, you can quantify it in a lab. But to have the POCUS, if it is positive, means more than 120, 150. And that's already high. So a positive test, a POCUS is as good as the quantitative one.
Well, that's very good to hear. Thank you. So yes, that would be my approach. I would do the blood test. I would then either try and book it in on another day when somebody like Louise is around, or if it's an emergency, obviously I would sort of step up and have a go. But my default would be to try and save that ultrasound for somebody that actually A, enjoys it and B, is pretty good at it.
Well, I was actually just going to say, I didn't know that about the ProBNP you can have a relatively normal LAAO and have a high ProBNP, which still indicates atrial stretch with systolic anterior. Like, I didn't know that, so I admittedly don't use ProBNP that much. And I think that kind of goes off both what we're saying, because I'm more comfortable scanning, I don't use it much. But now I feel like that would throw me if I did do that and it was raised, but my scan was normal.
Which is fine. So I think what is really important to define is we are worried with stage B2 cats. When you were saying you see cats with murmurs every day, you GA cats, these cats every day. So what's the percentage of cats that have bad disease? And we and others have looked into that, and it's around 10%. So 10% of cats with murmurs who have a big left atrium will be a B2. So those are the ones that we can push over the edge with IV fluids, with steroids, with GA. So it's 1 out of 10 cats. So the percentage is low. And as you were saying, if you are careful, use a gentle, cardio-safe GI protocol, then it'll be fine. But it's around 10%. But to answer your question, that's completely fine. Imagine NT-proBNP is very high, and then you do your echo and the LA is normal. The risk of that cat to go into congestive heart failure is very low. Either is a false positive or maybe there is SAM. Then if you want to know more, I think those are the cases that maybe you can refer to a cardiologist. But if you want to determine what's the risk of that cat to go into congestive heart failure, your POCUS as a normal left atrium, then the risk is low. Yeah.
Marvelous, because that's what I told the owner. And she's back in next month. But then the question becomes, well, what do you do with cats and murmurs. I mean, again, before we start, we had this chat before this thing. I know all about B2 and B1 for dogs. I didn't realize you did it for cats as well. Idiot. So what do we do with these cats with heart murmurs, especially this one, which is kind of borderline? I've given it a bit of Amadip. And then, but what do we do?
I do the same as you. It's different because when I see an owner, they've been referred to me, they're coming expecting the echo. So this initial conversation's already been had. So we're in these ivory towers in a referral population where the owner is motivated. They know what the price is going to be, that they're coming with all that hard work done. And actually, we do the echo in those cases, and that allows us to assess risk. And it comes down to atrial size, atrial function, in terms of risk assessment. Are there other things we look at specialist level? Yeah, sure. Okay, we look at diastolic function. We look at wall thickness, which can be challenging. We often see middle-aged cats who've got congenital heart disease that everyone was expecting it to be HCM, but it's not. We had a conversation this week, didn't we, Jose, on WhatsApp about, would you call this an HCM phenotype, or is this mitral valve dysplasia? And maybe we're coming down in different camps on that. So that shows it's hard, but fundamentally our risk assessment is the same as it would be in a primary care setting. I remember doing a lecture to a group of colleagues in Brazil. I have an amazing active cardiology scene in Brazil. And I was asked to talk about cardiac biomarkers. And I talked about, balancing context and cutoff value and in-house versus quantitative. And at the end, I sort of finished and said, echo kind of beats everything else, because the echo, you're seeing the heart, and that's where your risk assessment is. And at the end, one of the crowd put their hand up and said, so what's the point of doing cardiac biomarkers? What's the point of doing an NT-proBNP when we can do an echo? And I said, it's about accessibility, it's about cost. And they all went, yeah, but we can all echo. There's like 300 people in the room. And I said, it's about cost, it's about cost. And they said, echo's way cheaper than cardiac biomarkers. So in Brazil, and in other countries too, it might be $100 to run an NT-proBNP quantitative. And an echo by a qualified national specialist in Brazil in cardiology is about $30. So why would you run an NT-proBNP when you can have an echo? And the answer is you wouldn't. So I said, forget everything I just talked about for the last 45 minutes, because it's not relevant to the practitioners in Brazil.
Totally agree. But the cat we really want to find out are the B2. Are the cats that are on the edge of releasing a thrombus or developing congestive heart failure. So, that's why we want to find those cats, identify those risk factors, because those are the cats you want to start on antiplatelet treatment, right? Those are the cats that you want to ask the client, maybe check respiratory rate. Those are the cats that you be very careful when you GA them or give IV fluids. So our approach is we want to find those cats with a big left atrium to start them on clopidogrel or other drug. So that's why they are so important to detect.
Cool. So we crack out the clopidogrel and we get on with our day.
Yeah.
Fabulous.
I think it's very rare to find a cardiologist who would say, don't do this procedure, dentistry, whatever, for this pet to help their quality of life because they're at risk. I think we'd say, well, we've got to balance risk benefit, and the benefit's very high to day-to-day welfare. So we would always say, proceed. Don't use alpha 2s, careful with fluids, think about, recovery, respiratory monitoring, things like that. Kat, you mentioned about staging of B1 and B2. And that made me think, how useful are those sort of staging systems in a primary care setting? Is it something that you talk about to clients? Is it something that you reach for? And I think we're all familiar with mitral valve disease in dogs. Is that something that you would use to help you make clinical decisions and give advice?
Oh, we love an algorithm. If it's this, do that. If it's that, do this. Then don't do anything. Brilliant. Absolutely amazing. Give me a little list and a tick box, and I'm very happy.
Yeah, well, I say exactly the same. Iris, kidney staging, love it. It just gives you that sort of very objective, answer to then go forward.
What's a kidney?
I don't know, to be honest. I'm just making it up now.
admittedly, I use the staging really frequently in dogs. And I couldn't actually tell you the last time, this is really bad, that I've talked about the staging in cats. Now, that might have been because I've forgotten that existed.
I'm exactly the same.
I now remember it because on the, is it the ACVIM, it's got the colour box now. It's coming back to me in the circles of the H phenotypes. It's coming back to me. So I haven't used it. I'd use it a lot in dogs, and I find it very useful to put things into context. And I now feel like I should go back, but I going back to what everyone said, I think it's how we communicate what that murmur may mean, if we're going to go under anaesthetic. So I get a lot of owners, they've got a murmur, cat with a murmur. All right, you're not bothered about doing it. We'll reevaluate your next booster. But if it has a general anaesthetic, we're going to maybe recommend something based on the age, the breed, the bloods, the da-da-da-da-da. But no, I haven't used the grading, and I'm not sure.
But I think that's very common. It's not bad. And the reason is we know mitral valve disease staging very well because there's an intervention we can do when they are B2, right? There's a drug, there's medication out there, pimobendan, that we know we should start at B2. In cats, so far we have no drug that has been shown, no clinical trial that has been shown, okay, it's useful in B1 and B2. That's why we don't talk it that much. So it's completely normal. And it's very common that people are not aware of staging in cats. But now times are changing. So there's, as many of you might know, there's a drug called rapamycin that, well, rapamycin has been there for a while, but has now been used in cats as an anti-hypertrophic drug. It's called Felicin, has been launched in the US market and will very likely come to Europe. And so it will be very important very, very soon for us to figure out which cats are B1 and B2, because our approach will change. Besides giving an antiplatelet drug, it might very well be that we will have drugs out there that will change how the disease progresses. And so it's more important than ever to try to start understanding what is stage B1 versus B2.
I feel less bad.
Yeah, I think going to the drugs a bit. I mean, I still remember very vividly, and any RVC graduates probably will remember the 4 horsemen of the apocalypse. It was how it was taught at uni. It was the 4 drugs. And then basically 5 years ago, I was doing that, and a cardiologist was like, no, cats just need clopidogrel and furosemide. And so now my question when I'm scanning a cat is, does it need clopidogrel and furosemide? And in dogs, is it B2? Does it need PMO? They are really, in a GP setting for me, they are the 2 questions currently. And absolutely, rapamycin will change that. But I think that's where we're at currently.
And in the referral practice, the same. Those are the 2 drugs that we know it works. And owner compliance is a huge thing. We cannot give 2-3 different tablets to cats. We don't know if RAS inhibition helps in cats. And so that's also our approach. Clopidogrel or rivaroxaban and furosemide are the drugs of choice. You know?
How do you approach those conversations about polypharmacy? Because I think that's a big issue for us. When we see heart failure, we go, "Oh, okay, great. You've already been on pimobendan." I was going to name a brand, but I shan't. And generic furosemide, and an ACE inhibitor and spironolactone, and maybe as things get bad, a different diuretic and afterload. We're talking about 4, 5, 6 medications in some patients. That's a big ask for a person to take those tablets, let alone give it to their pet. How do you even approach that?
Is this in dogs or cats? Because cats ain't going to happen.
Let's start with dogs.
I have been very lucky that the majority of my dog owners, perhaps that's because I'm more confident talking about the stage and the progression and what will happen if they did or they didn't. I have been quite lucky that I've had dogs. I don't think I've had them on more than 3, though. I think it's Pimo, furosemide. I think the last time I spoke to you about ACE inhibitors, it was and on the ACVIM they weren't sure whether it is or isn't useful. So I
deny all knowledge of this conversation.
Sorry, didn't exist. So I think I've been lucky. The majority of the dogs have been very compliant with it. I think expense has been a limiting factor in some of my owners, if we can write them prescriptions and things. Cats, the last 2, I know there's the liquid version of, I call it clopidogrel as well. It's not meant, that's clopidogrel, whatever. I find that would be very much challenging in cats, multi-pharmacy, polypharmacy, whatever.
So my tactic with this is whenever I get the referral report back, I basically say, can you now also give me a priority list on your medications? Right. So my very basic brain would say that Pimo over ACE, and then the frusemide is basically going to be the thing that makes your dog feel better. So one's quality of life, one's going to work behind the scenes, and then the rest are sort of like to fine tune, the stats, as it were.
Well, I mean, this is contextualized care, isn't it? That's what we're all supposed to be talking about these days.
100%. Yeah.
James. So will you just have a conversation? Is this realistic for you or not? Well, and you prioritise the list, and cost comes into the conversation for us in first opinion, and we figure out what works best for that animal and that owner, and that is, there it is, the heart of vet med.
I think there's a point where it gets out of my remit. And when you're talking about 5 or 6 drugs, that's where I go, cool, no, this is not in my remit. This is beyond me. This is where I need cardiac input from a specialist. And we get those cases where they're on frusemide and torazamide, and and you're like, well, I'm sure I was taught it was one or the other. And then you're like, oh no, the cardiac report says do both. Okay, cool. Oh, and 3. Okay, 3 of those. Oh, fine. Okay, yeah. So if I'm making rogue calls, I'm only doing that with an EBVS guy behind me. I'm not doing that on my own.
One of the hard things about working alongside specialists or referral vets in managing a case is trying to get them to agree on how to manage something that's that complex. And I think when there's a consensus, we all kind of go, oh yeah, okay, first line, we would do that. But then when they get outside of the consensus, or they start misbehaving, they start becoming refractory to diuretics, then it starts getting a little more challenging. And we may have different approaches, but certainly I know that I differ in approach to colleagues I work with day to day, because there's no consensus and we have different experiences. And just like you guys must differ from your colleagues in how you approach things, because there's not a defined evidence base for something.
Okay, so we talk about cats. How's your approach to dogs? So again, the same scenario. Asymptomatic dog with a murmur. Is it different from cat? And how do you stage valve disease?
Is it a cavalier?
It's a 20 years old cavalier.
Well, dogs are easy. So when I talk to cat owners about heart murmurs, I say, bear with me. And I start talking about dogs and heart murmurs and how it's this lovely linear process, and gradually it gets loud. And then at some point they go to heart disease. And I'm like, cats don't do that, and then that helps me with that conversation. But I love it. I mean, so it's just, how loud is it? Come back. What breed is it? Get the Cardiology app. Others may exist. I don't know. Measure its resting respiratory rate. That was brilliant. Thanks for that piece of research. Love it. And then we all get on with our day until at some point or other it needs some drugs, and we keep an eye on it. It's just so easy compared to cats.
Well, yeah, basically that's it. I think the resting respiratory rate is probably one of the most simple yet useful tools that ever kind of came onto the veterinary scene, because it was just this immediate thing that we could give clients to do, engage them again in their pets, sort of health and welfare, and it just gives a very objective sort of parameter to say, over this value, we then need to do something about it. So I think that's the same. It's heart. For me, it will be the heart rate, the resting respiratory rate, and that's where I start. And if that's all up, then that's the green light to say we need to do some more. If they then don't want to do anything, then as a minimum, at least frusemide is not expensive to throw in the mix if we need to go down that route. But hopefully not at this point.
Dogs I find easier in one respect. So cats, I feel like they either come in wanting to die or they're not dead. And they either have a murmur or they don't have a murmur. So you have to decide, or the murmur is there, you panic, you put them under anaesthesia because the owner doesn't want to do something, then the murmur goes and you're like, what's happening? Whereas dogs, I feel like Kat said, there's like a linear approach. Have we got a murmur? How loud is it? If it's maybe a physics, so my Finn has, I thought it was like a 5 out of 6. And then lovely Brian Love was like, it's a physiological murmur, stop it, he's fine. I feel like dogs, there is the approach, we know we follow the consensus guidelines. It's just then dogs complicate it when they have the murmur, but also the other respiratory signs where we have to then figure out what's what, and that goes back to the lecture that you gave before. I've had a couple of tricky cases recently where I've had the dogs that are they'll be stage B2, they're on PEMO, they're then coughing, so they come to me on furosemide, and then they're in heart failure, and then I've had to unpick everything with your support as well, where it's finding it stressful. So I feel like cats, they're more frustrating to know what to do, but when you do something, it's a bit more there's less paths to go down. Whereas dogs, I feel like they have the murmur, but then is the murmur causing the signs that you're seeing? Because we're unlearning that coughing is probably not heart, it's probably something else. And that to me has been the biggest frustration. It's the coughing dog with the 4 out of 6 murmur that's on PIMO, that's now been put on FRUs, and then the FRUs slightly improves it, because we know FRUs might have an impact on airway, and then unlearning things for ourselves, telling the owners, I don't think that's heart related, we need to go down that beaten track. In summary, I talk a lot, I'm really sorry. I find dogs easier to approach with scans if the murmur is maybe louder than 3 or there are other symptoms. I will do an echo. It just gets complicated because they then get respiratory disease on top.
Yeah, I think we all identify with that problem. Kat,
I have a question. If you're not confident in scanning a dog, you can X-ray their chest, can't you, to look at the size of their heart? What do we use to knock them out, please?
That's
and is VHS worth doing?
There's another one now for the atria.
You're actually kind of taking my questions, because I was going to ask the panel, how frequently do you reach for radiographs in these cases, particularly if you're not mega confident? I'm doing loads of echo. How often do you reach for radiographs and think, yeah, okay, I'm good with that test?
Well, I'd say it depends who's in the practice. If I'm totally honest, I think if it was myself, I would probably I'd reach for X-rays. If it felt critical, if it didn't feel critical, I might wait and suggest that we have the ultrasonographer at the same time as the X-ray, so it's not 2 procedures for the dog. But I think I do still use X-ray, and I do still sort of go down that route.
I would go for POCUS and RADS if possible. If I could do RADS just under TORB and some sandbags, then I would do that. If I've ever got a respiratory or coughing animal, I'm pretty much always going to give it TORB, and potentially some IML Faxam. That's where I would go for sedation protocol. I have a love-hate relationship with VHS. I don't do it anymore. I used to do it all the time, and then I was like, why am I doing this? I never use it. But also I think if the other question is I would want to ask before deciding on chest rads versus maybe POCUS is, do I think it's wet? And I'm going to ask that question first. Do I think I'm going to see fluid in the chest? Because actually, is there anything wrong with giving it furosemide before doing some chest rads?
No.
I think if your pre-test probability, and the risk of sounding like Adrian Boswood, is high, that they've got pulmonary edema, give them some furosemide. Stabilize them. The bottom line has always got to be that patient's welfare, right? And if the furosemide facilitates a stable diagnostic test, then it's probably a better diagnostic test. So I agree with you. And for the sedation protocol too, that's what I would do.
Yeah, I totally agree. I totally agree with the furosemide if you are worried and the dog has respiratory signs. But I think there are 2 different cohorts. The dog with a very loud murmur, which you may want to figure out, is it a B2, should I start pimobendan? Or a dog with respiratory signs and cough, which we want to know, is the dog in congestive heart failure? So if you focus on those ones that are asymptomatic, you just detect a very loud murmur in a routine consult. Would you echo those cases? Would you do thoracic radiographs? Would you refer those guys? How do you decide when would you start pimobendan?
So I would echo them, but that's because I'm more comfortable echoing. And I do chest X-rays, but it tends to be for the coughing ones where I'm trying to convince an owner it's not heart related. Or so, for example, we did a dental procedure on a staff advanced mitral valve B2 on pimobendan, and I wanted to just look at the heart in the chest, so kind of as a monitoring tool. I will echo and I will follow the consensus. So I'll measure the left ventricle, internal diameter, LAAO, murmur sound, if it is at that B2, if they're both enlarged PIMO. I've had a couple where not both of them reach the criteria, and again, speaking to Kieran, it's difficult sometimes to say, oh, should I hang fire and wait 3 months, 6 months? Or if the murmur is and it's a cavi, I have erred on the side of caution. If someone's not able to have another scan in 3 months, I will just put them on pimobendan.
Yeah, I would also recommend echo straight away, but equally when it comes down to caution, I think the question I've heard asked more in the last 6 months than ever before is, can we not just start pimobendan? What's the downside? If you think it is, and on balance it's potentially B2, put them on Pimo.
See, so that's, which of course is everyone's thought, but I think for me, again, going right back to the very sort of basics of that client communication, I think Pimo is such an expensive drug that for me, it's that argument around false economy of thinking, well, yeah, we could skip all of this, but actually, if you can just invest in at least an echo, ideally then with maybe RADs as well, then actually you know why you're doing something. So that will be, when I have those cases that come in and they say, can we not just skip all of that? If you think it is, probably it's just cost, I would say. It's like, because if the dog's got 7 years ahead of it or what have you, and it doesn't even need it, then that's going to be a long lifetime of a drug that actually doesn't necessarily need.
Have I made this up? Are they doing another study on this, that you can put them on Pimo by the sound of the murmur alone, or have I completely made this up?
So,
have I made this up?
No, you haven't. I think we've talked about this a little bit, haven't we? There is a published trial where the authors, this is the RVC team, and what they did was look at Vet Compass data. It's a really, really, really interesting paper, and it's open access, so you can get it without being an institutional member of a journal or whatever. But the paper is designed to see if you can use real world clinic data to validate the results of a clinical trial. So what they did was they looked at dogs who had a grade 4 murmur and were small breeds, over 6, probably mitral valve disease on the balance of probability. Those that had pimobendan and those that didn't have pimobendan, and what their lifespan was. So big data, dirty data, but hopefully so big that it irons out all those little kinks and you can see the bigger picture. And actually the dogs who were given pimobendan did live significantly longer than the dogs who were not given pimobendan. But obviously this is retrospective clinic data. So what that means is that some of those dogs had an echo and radiographs or whatever to say, okay, this dog's got a big atrium. So there was a bit of selection bias there. And maybe there was something in those patients that meant the vet kind of pushed a little bit for the imaging, or the owner wanted it. And in the other ones, maybe there wasn't something. So I think it is dirty data. What the authors were trying to do was prove that you could use this data to try and replicate clinical trials in the real world. They were not trying to show that if you put a dog with a grade 4 murmur on pimobendan, they do better. However, I've been thinking about this in the background as we're talking. And my question is, well, actually, quick straw poll. First of all, everyone has to close their eyes. This is great in an audio medium because it's a visual thing. So apologies to anyone listening later on. Maybe we'll edit this bit out. Everyone close their eyes. Put your hands up if you've ever given pimobendan to a dog with a murmur based on the murmur alone. Okay. Probably 25%. You can put your hands down, open your eyes. I love anonymous polling in a podcast. So probably 25% of people, which means that, now, obviously that comes from a place of wanting to do the right thing, right?
Well, I mean, now ask them how old they are.
Yeah. I mean, I can see. No, I think it's hard, isn't it? Because that comes from trying to help, but I don't think it always helps. But I think we've all done it at some point because an owner wants it to do it and they're really motivated, but this month they can afford 40 quid or whatever for their size dog, whereas they can't afford 500 or 800 or 1,000. So, but I do think it is a false economy, and I do think it changes how we think about the patient. So I'm not sure it's harmful, but it's not necessarily our first choice, being diplomatic.
The big question is it going to do any harm? So hopefully not. Marvellous. But then we can monitor the dog's response to that. What's its resps? What's its heart rate? What's its cough? Like we used to back in the day.
The problem is when they are in stage B2, if anything, they might be mild exercise intolerant. So it will be really challenging. Then, of course, there's the placebo effect. And so it will be the owner is paying an expensive drug, is giving the drug, the dog will feel fantastic, I'm sure. So it's tricky then to monitor their response when they are asymptomatic. The resting respiratory rate in stage B2 should still be normal. And so the resting respiratory rate will not help with stage B2. So what I think is really important to say is stage B1 may last more than 5 years. Stage B2 lasts 3 years, 1,000 days. And many dogs will never progress because they will die of something else. And that's to me the argument. Why would you start a drug in a patient that the disease may never progress? Or they will be on the drug 3 or 4 years before something happens. So I totally agree with you. There is no urgency to start a drug straight away. And there's data out there showing that if you are not sure, just wait a few more months. And that's to me the argument. We should not just put every dog on pimobendan. It's like maybe we should all be on aspirin because we may all have a stroke. And how many of us will ever have a stroke? And so it's just taking a drug and all the changes in dynamics that we talk a lot between the client and the owner and their pet when they start a drug and how that will impact their decisions, because then he's a cardiac patient, right? You start pimobendan, from that moment on, that patient has a heart disease, and this will impact how they take decisions. So to me, I would not recommend to give the drug just to every patient because many of them will never need it.
I wanted to ask about telemedicine. Is this something that you reach for with these cardiac cases or not? Yeah.
Are we talking remote support for?
Yeah, remote support either from a referral centre or from a commercial organisation.
No.
Right, so I'm just going to go back to what you said, Jose, and ask what is potentially a really stupid question. So you said that B2 can last 300 days, but aren't we supposed to start the B2s on pimobendan because it gives them a longer life? Right. It delays the onset. So are you suggesting that if we didn't start it, it would last? Was that 300 days with meds or without meds?
Exactly, without meds.
900 days.
So 900 days, 3 years with no medication. And so pimobendan will delay the onset of clinical signs by 15 months. So you get 1.5 years.
So 3 years and 15 months. Right, okay, thanks.
Yeah. My point was that it's not urgent to start a drug. And again, and Adrian Boswood said that in our podcast, so you can listen to our previous episodes, and that most dogs will die with the disease and not of the disease. And so, because the disease is so common, so common, that many dogs will have it and they will never progress. Yeah.
Right. Okay, thank you. Telemedicine, no. Sometimes I Instagram Kieran. Does that count?
I don't think we can call it telemedicine. Conversation.
So telemedicine, I have a 50-50 on this. Vet to referral centre, I love. I think it's great. I think it's really useful. And the idea of you being able to, is this what we're talking about? Like you being able to read the screen whilst I'm holding the probe?
Oh, right, yeah.
Absolutely love that. I would 100% do it. The other reason I love x-rays is because they're so easy to ping over to referral centre. So for me, vet to referral centre, telemedicine is a huge part of my job and I rely on it a lot. Telemedicine between vet and patient, if the laws should ever change, after COVID, I feel is something we should really protect against, because I just think that we saw how wrong that can go with owners trying to sort of describe a patient or, chase the dog around with a phone and trying to, I hated it personally. So that would be my take on telemedicine.
Because I've got confused. Telemedicine is in, why is this so hard to understand?
Sorry, I should have been more clear. I meant, how often do you reach out for remote support with these cases, rather than the owner being at home and you kind of dialing in or them dialing into a console? How often do you reach for a support from referral centres or commercial telemedicine services?
We did have a telemedicine provider that I don't know if you're allowed to mention things, but that a lot of my less experienced colleagues, and I've used it as well, would use with our cases, and you could upload pictures or scans, and I feel that they had found that very useful. I I don't use it as much as I should. Like I said, I get maybe some informal advice from yourselves if I need some support with cases. I love the idea of where you can like dial in and a specialist can be with you scanning. You must do something with the ultrasound machine so you can scan in real time together. I think that's fabulous. And I feel like that would enable us as GPs to learn more with specialist support. Hope that doesn't take the work from you guys though. But I think there's a gap with the telemedicine in things like echocardiology, because I feel like when I qualified, everything was referred. Immediately everything was referred. And now I feel like we're wanting to do more and more and more. And I know sometimes I'm like, oh, when do I when should I refer? And mine tend to be the refractory ones if I'm not sure about pulmonary hypertension, and they would be the ones that I would love to have some real remote support. But obviously, if we don't, we would refer to you guys.
Yeah, I think we're moving way more towards that. And now I've got my business owner hat on. It is cheaper for me to get a cert holder peripatetic cardiologist to come in and do a scan than it is for me to use a telemedicine service that provides that support. And I think there is real benefit to those services. VVS is the one we're all referencing, I assume. There is real benefit for that. But purely from a admin, customer-facing, client-providing service, being able to get a peripatetic into the clinic for a cheaper amount is great. And I think you're right, Louisa. We're seeing more and more specialists and cert holders doing peripatetics, particularly in London. And I'm in probably a privileged position being in London, having so much at our fingertips. But the referral cases are few and far between for me these days. They are the ones that are considering a mitral valve replacement. They are the ones that are early onset. They're the ones that are refractory. They're the ones that are weird cats. They're the ones that we can't deal with in-house. So that would be one.
So I think we have 30 seconds left for each of you to tell us your final thoughts, any stuff you would like to discuss.
So many thoughts. When I think about this sort of stuff in GP, I feel like I speak on behalf of lots of us when I think the complications are, we have got the mitral valve stage B2 that needs a dental. I get a lot of ex-PDSA clients that have been told their teeth are horrific. We can't do the dental because of the heart murmur, and that really boils my blood. So how do you guys feel like you approach a general anesthesia in these ones? Do you feel like you avoid a drug altogether? What about, so I've become a little bit more confident because I'm a bit better at scanning. I will use small doses of medetomidine if they're not B2. I will avoid it in what did I just say? B1. I'll use it in B1. I will not use it in B2. What do you guys do? Do you shy away from your GAs? Are you happy to go full steam ahead? What do you...
Yeah, I'll GA anything.
Yeah.
Yeah, I think... I'll GA anything. Get on the table, cut it, do it. I think that's probably my thing is particularly if you're a young vet, have a go. One, if you've got an ultrasound in the clinic, just do it. It doesn't matter if your boss tells you you've got to charge for it, tell them to do one. Just do it on every patient in, get a scanner on the dog or on the cat. Because if you don't do it, you won't get better and you won't be able to provide the service. And we are entering 5 years of really difficult financial times. And if we can offer a quick scan to give someone peace of mind, or to give your nurse peace of mind when they're looking at the capnography or they're doing that GA, just that little bit of confidence going, oh, actually, no, the LAO is okay. We're good. We're happy. We'll monitor BP. We'll just take this on and use Alfax and Medaz instead of Dexdom. Then that is what we should be doing as GPs every time.
Well, my wrap up, I'm just going to say that, all of that, and thanks for having me. I feel very lucky to be on this panel. No, I think that, scanning is obviously so useful. I probably won't stop doing ProBNP. I'd still find it really useful. And I think I would GA with a murmur, on a risk benefit. That's my roundup.
Can I just briefly echo what Rory said? Ultrasound is only getting better and better and better. And ultrasound is kind of an extension of the clinical examiner. It's like the new stethoscope. So I totally agree. Young vets, old vets, you should just try to get as best as you can on ultrasound. Do ultrasound courses because it's such a useful tool. Everyone has an ultrasound machine. You don't need a fancy machine. And as Rory said, just give it a go. And then if you are not sure, send the images to your referring cardiologist. Everyone is more than happy to look at images and advise you and tell you what we think. So just use the probe. Totally agree. Yeah.
I've got to think of something wise to say now. I think that cardiology is a discipline which is within the reach of every single person in first opinion practice, isn't it? Because we all have a stethoscope.
I would absolutely agree.
And I think that it's one place where we can make a real difference if we are proactive. And scanning an aorta and a left atrium is not as hard as you think it is.
Then you get to a point like us and you go, oh, it's much harder than I used to think it was. But I take your point. I think that assessment is within reach. And I think if you do it, it'll change how you work, which will improve things for your patients. We're out of time. So I wanted to say a massive, massive thank you to our wonderful panel. Please give them a round of applause. And thank you to everybody for coming in a very busy LVS show. Enjoy the rest of the show. Thank you very much, everybody.
You have been listening to the Animal Heartbeat. Thanks very much for our listeners.
Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from or on our YouTube channel.